Hi friends, welcome back to Coffee with Ravi. Today we have a special episode and we have with me Katie, who's helping us with some of our social media stuff. Katie, it's a pleasure to have you on.
Thank you.
Yeah, today because March is Colon Cancer Awareness Month, I thought we would do a question and answer format and try to make it more informative to all of you. So this is to raise your awareness about colon cancer and how to prevent colon cancer and questions surrounding it. So Katie's put together a few questions and we'll try to do this in question and answer format. So Katie, what should we talk to our patients about today?
So this is the top 10 questions patients have about colonoscopies. So the first one they had was, do I really need one if I feel fine?
Yeah, absolutely, because colon cancer, colon polyps are very silent. In other words, they cause no symptoms. So the only way to find them is to look. And by looking and finding things early, we mitigate colon cancer risk.
The next one that people asked was, is the prep actually worse than the procedure?
Probably. Yeah. So the prep itself is the more taxing piece, right? You have to drink it. The taste is not that great, even though the preps now have become improved. But once they come here, it becomes an easy thing. The sedation is very effective. People don't remember the procedure. It is done very comfortably and privately. Our staff are wonderful at making patients feel comfortable. So it's the prep piece is, of course, the more challenging aspect of the whole procedure.
And then going kind of along with that, they want to know, will it hurt?
Yeah. No. The majority of patients tell us that when they go to sleep and they wake up. Very rarely, it's hard to estimate the depth of the sedation. So occasionally patients are floating towards awakeness even though it's not apparent to the nurse anesthetist or to the gastroenterologist. So occasionally people say, I woke up for a few seconds and I felt something. But that something is not in the nature of pain, it's in the nature of something going on, and they go back to sleep. But besides that, the great majority of patients report that it's a comfortable and safe procedure.
How long does it take?
Yeah. From the procedure itself, probably from the time the scope is inserted to the time that it's removed is probably in the range of about 15 to 20 minutes. However, from the time the patient comes in to the time they leave, it's about somewhere between the 2 to 2.5 hour range from the time they walk into the building to the time they walk out, including getting people ready and getting them out. It takes about that much time.
What are you actually looking for once you're in there?
Yeah. It's a good question. We are looking for polyps. Polyps are like little growths. You can think of them as like little mushrooms that are growing inside, or sometimes they can be flat. These are little growths that can, over a period of time, develop enough problems to become cancer. So if you can snip them off and take them out from the root, you prevented cancer. In addition, depending on the reason to do it, if you're doing colonoscopies from a standpoint of trying to figure out if there's why somebody is bleeding, or if we're doing it from this point of trying to find why they're having diarrhea, there's different things you can find where the inside is inflamed. It can be red, it can be VP. So those are different things. But from a colon cancer prevention standpoint, that's different things you find.
And then what happens if they do find something in there?
Yeah. So if the polyp, most times the polyps, if we find the polyps, we can take them off. If there's inflammation, and we can take little pieces of tissue, what we call biopsies, and we have our own pathology lab. We sit with our pathologist and we can put it together and we come up with a diagnosis, because trying to figure out what's going on is a bit like detective work. You got to kind of get the endoscopy or the colonoscopy information, you get the pathology information, you get the patient story, and you put it all together, and that's how you can make people feel better.
This is coming from patients. Is it embarrassing?
It is not embarrassing in the sense of any kind of, we handle things very privately and discreetly. Certainly the idea can be of the thought of a colonoscopy or can be a thought, but the experience doesn't match up to that because it's done very privately, it's done very discreetly, and I think it's more a idea in people's mind that we have that that we have to kind of just live with and go
that
with
makes
it.
sense. And then how often do we need to get one?
Yeah, sort of depends. From a screening for colon cancer standpoint, it starts at the age of 45. What we're noticing is that colon cancer is moving to a younger population. We don't know why. Reasons could be there's a syndrome called metabolic syndrome. As we gain more weight, especially around the middle, our insulin levels start going up. We start developing higher blood glucoses or diabetes. In some way, that seems to be multiplying the cancer cells. So that could be one reason. There could be some environmental factors, whether it is some pollution that we are not yet aware of, pesticides, microplastic, something that we are eating or consuming, whether it's more red meat, something that's happening inside the body in the gut environment. These may be reasons why colon cancer seems to be shifting to younger people. So we start at 45. After 45, if there is polyps that are found, depending on the size and number, if it's more than 3 polyps, or if it's a polyp more than a centimeter, it's every 3 years, and it depends on the type of polyp. If somebody has family history of a colon cancer, in other words, a first-degree relative, meaning mother, brother, son, father, that's first-degree relative, you do it every 5 years, irrespective of whether you find polyps. So those would be the general guidelines, but starting at the age of 45.
Okay. Here's another question I have. If you did have family history and you were not 45, would it be smart to start?
You start 5 years ahead.
Okay.
If it's a younger colon cancer, there's 2 types of cancer. If it's premature family history of cancer, in other words, developing before the age of 65, you would start at the age of 40.
Okay. Can you go back to normal life and everyday things right away, or do you need...
pretty much right away. The medicine we use is called propofol. It's very monitored anesthesia, so we very careful with how the patients get the right amount of medicine. But the nice thing is people wake up. We recommend not going back and driving or consuming alcohol the same day because there may be some trace of the drug. But besides that, you can resume normal activities, not be around moving machinery, not drive, not put yourself or anybody else at risk, but that's standard for just that day, and then go back to normal work and lifestyle the next day.
Great. Can you tell us about the role of, is it Colaggard?
Yes.
For screening?
Yeah. So the best way to pick up colon polyps, which are the precursors, is to have a screening colonoscopy. Colaggard is a test that combines the detection of a little bit of leakage of blood and some tumor cells, and it detects both of that together in the stool sample. It doesn't do it 100%. So if a colonoscopy picks up 95% of colon polyps, a Colaggard will only pick it up 60% of the time.
Okay.
Colon cancer detection is much better with Colaggard, almost as perhaps a little lower than the colonoscopy, but certainly there. But what you're trying to do is not find colon cancer, but find the precursors, which is the pre-stages of colon cancer with these polyps. So in that way, colonoscopy still is a better way. For those who are unable or unwilling to do it, maybe the second option would be Colaggard. But some sort of screening, I think, is better than no screening. But colonoscopy is the best form of screening that we have, as recommended by American Cancer Society, as recommended by the American College of Gastroenterology and all other professional societies. Especially there's a society called USPSTF, or Preventive Services Task Force. That's the gold standard, and they kind of stage the strength of the recommendations, and they do, I think, go along with what I've just stated.
Great. I have another question. With that, then, would you recommend the Colaggard earlier than age 45, or with that?
No, at the same age.
At the same age. Okay. And the last one is, they want to know, is it worth it?
Absolutely worth it, because I think more the more we can prevent cancer, but cancer risk can sneak up on us in many ways, and the more we can mitigate it, all of the problems that come with cancer diagnosis, the stress of it, the surgical aspects of it, or the chemotherapy of it, all of that sinks the quality of life for a period of time. So we should, in all aspects of life, especially in the health aspects that we're talking about, try to mitigate those problems by getting ahead. Have periodic skin checks, make sure that the mammograms and the pap smears and the prostate exams and the colonoscopies, all of these are, you're trying to pick things up earlier, so that you're actually dealing with things at a very early stage, or even preventing them. So from that standpoint, anything we do to prevent cancer is helpful.
Yes. Well, this has been very informative. Do you have anything else that you want to share?
No, I think if people send in questions, we can always pick up this question and answer sessions. I want to see what our patients say about this format, and whether they find it engaging. I'd love to hear back from you. So thank you for all your encouragement and your comments. Dear patients and friends, we'll continue to put this out